I have no conflict of interest here in this. First, I'll give a small short information about Oman. To those they don't know about Oman, Oman located in the Middle East and South Arabian Hard. The keratoconus, the commonest, common than many other countries. We did this a study in Oman about the keratoconus prevalence, and we found almost 7%. And Oman country, very old country also, where we can, the population living together since long time, some tribes staying and families living in some cities and small villages together since maybe thousands years. And that's why when we did this study, we found some families, they have up to more than 20% prevalence of keratoconus on those families. And this is the reason maybe you can see this some inheritance in these families where the main, those susceptible to develop keratoconus or ectasia of the cornea. And it's published on Oman Journal of Ophthalmology. Our ophthalmology center serve almost more than 1/4 of the Omani patient with keratoconus. We have experienced more than 10 years now in the field of treating keratoconus. Actually, our clinic started, almost one of the first clinic in Oman started CXL treatment in Oman. And we have pediatric also CXL clinics, and we have a dedicated keratoconus clinic and contact lens clinics where we are seeing, we are doing every year around in Africa of 150 cross-linkings in our center by itself for local patients. We cross also pediatric, but pediatric clinic, we cross them all from the beginning without even waiting. But for others than pediatrics, usually till last year, we cross-links only those cornea above 400 microns as per protocols. And most of the time we see them two visit at least, or one visit at least before we start cross-linking to evaluate the patients. Keratoconus of thin corneas was not there in Oman. We used to follow all the normal protocol, which only above 400. And those patients, they are more than 400, less than 400 microns, we wait. Of course, they get contact lens or glasses, we wait, they get advice. But many of those patients, they progress to eye drops or scars, and those patients, they need some type of keratoplasty. That's why we were, and the second problem in Oman, we have many patients, young patients, they present to us late. They don't come except when they have already their vision very much affected. I don't know why, but most people, they wait. That's the problem, the challenge which we are facing. That's why we are always looking for some customized way to treat those patients. Especially most of those young patients, they come with clear cornea. No eye drops, no scars, no opacities. So we think that we can help them not only to wait till they develop, they get advanced, and they need more invasive treatment like keratoplasty. We know from the different protocols, there's a stromal demarcation differ from type of treatment to others, EB on or EB off, and type of Dresden or other types developed. There's so many developed protocols, and from this we can conclude that from this like this graph, we can conclude that different protocols has got different parameters, so different depth on the stroma, demarcation depth. So most of them develop that so that safe to the endothelium. From here we took the idea of we may develop something parallel customized treatment for some of those young patients. We can save them, those they have cornea thickness around nearby 400, like 20 micron less or so, without any official or other labeled protocols. We can see from this photo also here, EB-on always gives a higher demarcation in the stroma. Sorry, this one here. And if we go to the accelerated one, also deep, but if we look at the Dresden CXL, still the best actually. Dresden CXL still the best from the demarcation line, but because of the time it takes long time difficult for the clinician and for the patients. Most of people, they try to avoid, and they're going to accelerate some type of accelerated type of treatment. Here from this graph, we can see from this graph that showing comparing riboflavin soaking time, power and time and energy dose, we can predict how deep the demarcation going to be in the cornea. So from this, we predict that, and we can say how deep, and we can modify and customize those parameters so that will safe for the cornea to do cross-linking even for those patients sub 400 micron. Here, and we know all that Professor Cosimo Mazzotto has published nomogram recently, end of 2019. It was published in the journals, and his idea same, that to customize the parameters only, not to use another machine, same parameter, but different numbers, so that this be safe for the cornea, not to affect the deeper layers and endothel of the cornea. And actually, we were looking for this. Actually, myself, I met in our center, we see so many patients late comers. When they come to us, they are already below 400, but they have clean cornea and they are young, still around 16 years old. So we feel very bad to wait only for them till they develop more advanced findings. So we were looking for some type of treatment. From here, the Professor Mazzotto has published in his bachymetry-based accelerated cross-linking the nomogram for standardized treatment of all thickness produced ectasia cornea. I was very happy to read this one and to see this, the safe type. Also, he published pulse versus continuous light accelerated corneal collagen cross-linking in vivo qualitative investigation by confocal microscope and corneal OCT. Pulsing the light during CXL treatment induce a higher penetration of photooxidative effect, at least 40 microns over the continuous UV light exposure, as demonstrated by confocal and OCT. That means continuous illumination can be an option for treating thin cornea because we'll give like 40 microns safety margin. Here, what we use for the last 10 years, we use the standard accelerated KXL. We treated more than 1,000 patients in Oman, maybe much more. But we use the standard way, which is accelerated KXL, and we use here, we can see here 30 milliwatts UV powers, 7.2 joules fluence, and pulse illumination 1-to-1 total 8 minutes, and 10 minutes soaking with isotonic riboflavin 0.1%, 1 drop every 2 minutes. No riboflavin during UV light. So far, we have achieved good result. Our failure rate is around 5 to 7%, despite having many advanced cases. When we say 5 to 7%, we do more than 150 patients a year, and most of the many patients, not maybe 1/3 of the patient advanced cases. Here we see this late present, unfortunately common in Oman. This is the case which I'm going to present. Very interesting case. It's 16-year-old school girls. Can see here. First visit at ophthalmology center in September 2019. The chief complaint deteriorating vision in both eyes, not using glasses, not known to have previous ophthalmic or medical problem, found to have both eyes keratoconus. Both eyes keratoconus stage 3, fogged stereo already blast, Fleischer ring blast, otherwise clear cornea in both eyes, no apical scarring. We can see here from this here, you can see Kmax for the right eye, 67.6, and Kmax for left eye, 57.6. Thinnest Paki, 368 right eye, and left eye, 389. As we can see, both eyes below 400, but left eye better. You can see here from pentagram topography, we can see the Kmax here, 67 for the right eye, and left eye, 57. And both eyes in KC3, and we can see the parameters on the cornea. what treatment, what high risk patient we have here in front of us, very high risk patient, age-wise, KC stake, and pachymetry wise. Risk of CXL complication due to thin cornea versus conservative management. We discussed this between ourselves and with the patient. We did counseling for the parents regarding all what could happen to those patients. Parents agree when we told them about the risk and what we are doing to customize to get better for the patient, and especially the patient is 16 years old. So what we use for this patient, actually this was without protocol, still nomogram still not known that time. That time in September was not published still, we didn't know about it, but we try ourselves to make our own little bit amendment for the protocols. So here we see we use EP off accelerated treatment for left eye, the better eye. Abnormal gum was not available at that time. Decided to go for continuous illumination instead of pulse to use less fluence. Stromal depth will be less, hence more protection of endothelium. A treatment setting for left eye, I said, the better eye, epithelium, as we do always, 8 milligram epithelium off, 8 millimeter, sorry. Fluence 5.7 joules and continuous illumination for 3 minutes. 10 minutes soaking with isotonic riboflavin 0.1, 1 drop every 2 minutes. Pachymetry reading, pre-op usually we do done 395. After removal of the epithelium, you can see here the pachymetry was 366. And after soaking with riboflavin pre-UVA, 390. So date of surgery was in September, same month, after 1 week of presentation. Follow up so far, day 1, usually we do day 1, day 7, 1 month 1, 3, 6, 8. No complication, as you can see here. No corneal edema, epithelium was healed by day 7, endothelial cell count 2,586 on day 7. We can see here Kmax pre-op 57.6 and all over, and was stable to 57.1 after 8 months of presentation. That's mean last 2 weeks ago we saw the patient again, and we can see thinnest. The pachymetry, of course, valuable, but because of epithelium not maybe changed, still lower a little bit. Vision improved very much, and also this one factors. We can see that from the OCT, you can see the demarcation where still there's plenty of safety margin between the demarcation line and endothelium. So this was successful. You can see here, and from topography, you can see Kmax pre-op 57.6 and post-op 57.1. You can see here the improvement, very clear improvement in all points. And also KC stake from KC3, the patient after 8 months going to KC2. That means there's improvement. You can see here the topography also. Compare for exams, pre-op, the progression very clear. Improvement there after the treatment. Every month there's improvement, and after 8 months, the improvement very clear from the parameters here. Now the right eye, the difficult eye. The right eye we were scared to do in the beginning, and then when we knew about the amnomogram, we discussed with Professor Mazota, and we got his advice as we are new in the field of such cornea, and he advised us to go for pachymetry between 350 to 400 protocols. And we did that. What we did for this patient, epithelium of same 8 millimeter, 15 milliwatts power, 5.7 joule fluence, and pulse illumination 1:1, total of 12 minutes, 10 minutes soaking with isotonic riboflavin 0.1%, 1 drop every 3 minutes. Riboflavin 1 drop every 3 minutes during UVA. Also here, what we added during ultraviolet application of UV light, also every 3 minutes we used to apply drops. So from the beginning, the calculated demarcation line was 280 microns, and stromal depth in average was between 250 to 310 for this patient. We can see here pre-op pachymetry was 365 for the same patient, and after removal of epithelium 348, and after soaking with riboflavin pre-UVA 366. What post-op? You can see here date of surgery done February 2020, and 3 months ago from today, no complaint. The patient came last visit recently. Epithelium was healed by day 7, endothelial cell count 2,558, and mild central haze, they were grade 2 noted in the last visit, which usually from our experience with treatment will go. The demarcation line we can see here, deep, but there's large safety margin for this patient. If you compare the Kmax during from first visit September 19 to February 20, the patient has progressed more than one number. And after 3 months, regressed and or stabilized the patient. And the thinnest spirometry, you can see it here, is progressing already, but here after that gets stable after 1 month, and here get low because could be because of the epithelium also. Vision, of course, did not improve because maybe of the central corneal haze, which we think that with time will improve. Here we can see, you can clear in the pre-op, the Kmax vertically 68.8 here, and that means better improved after 3 months, and we can see almost of the parameters has been changed to better Kmax. You can see here between first visit and second visit pre-treatment, the progression was very clear in all points. Kmax, if you can see here, all 48, which is 46. This here still, this first visit, second visit pre-op. Here, number C, the post-op, and this one 3 month post-op. We can see the differences, improvement very clear. In conclusion, CXL protocol can be customized to suit the bachymetry reading by adjusting riboflavin, soaking time, UVA power, and exposure time. Demarcation line can be used as an indicator for assessment of treatment efficiency. Nomogram is a useful tool to pre-calculate the demarcation line and adjust treatment setting accordingly. Thin cornea below 400 microns is no more contraindication for CXL. There's new hope for patients with progressive KC thin cornea.